I want to officially welcome everybody to Frankly Speaking About Medicine, Precision Medicine, or frankly speaking about cancer, precision medicine. We have this great opportunity to have Dr. Mark Juckett with us, talking about sort of the ins and outs of precision medicine and what it might mean for you. And we look forward to a great workshop and any questions that you have in the future. So thank you for being here, and take it away, Mark.
All right, thank you. Thank you. So my name's Mark Juckett. I'm one of the cancer physicians at the University of Wisconsin. And the subject today is precision medicine. And I think it's a great subject to talk about because you hear this term quite frequently. People use it a lot. It's a bit of a buzzword. And I think it's good to step back and really think about what it means. And that's really the purpose of the talk today. And so to be clear, this is the slides are coming from the cancer support community. They spent I think a good, invested time to develop a set of slides that has a lot of good terminology and things to remember. And so these are the slides that I'm going to use today. And of course, I'm happy to answer questions either along the way or at the end. Okay, let's see. There we go. Okay. So the overview, we will talk about what is precision medicine. We're going to talk about this idea of what a biomarker is. And I think that's a great term to use. There are lots of terms that are floating around, and biomarker, I think, really captures the essence of what precision medicine is about, how we use biomarkers to find the best treatment. And then this leads into this idea of targeted therapy. This is another buzzword that's used quite a bit, targeted therapy. What does that really mean? We'll talk about that. And targeted therapy is very closely linked to the idea of what a biomarker is. And at the end, we're going to transition to this idea of genetic testing about for inheritable cancers. And so this is a very sensitive and important area to think about as well. So this is the individual who helped develop these slides. And as I mentioned, the slides themselves were put together by the cancer support community. And but of course, the presenter, the sponsor today is our local Gilda's Club in Madison. I mentioned who I am. So I'm primarily a leukemia doctor. And so you might ask, well, why am I giving this? Well, because we're all of us in oncology are thinking about this idea of precision medicine. And in fact, it's one of the reasons that more and more from a cancer doctor point of view, we really need to focus on individual areas because it's gotten so complex. When I went through training many years ago, a cancer such as lung cancer honestly was pretty easy to learn about because there just was very little that you could do. And nowadays, lung cancer has gotten very complicated because for all the right reasons, it's gotten to become an area that we can do a lot. And so it's very important to know all the biomarkers and all the issues about lung cancer that are important. And it's certainly very true in my specific area, leukemia. So first of all, what is precision medicine? So the term is used in the same way personalized medicine is used. And this is really a way of, rather than treating us all as the same, let's think about the ways that we differ. And not only about the way we differ, but we know that cancers differ as well. And so I used the analogy a little bit ago of lung cancer, and we think of lung cancer as one thing, but it's really not. Lung cancer is just one term for many different kinds of cancers that are very unique, even to the point of being unique within each individual that has it. And so when we talk about personalized medicine, what we're really talking about is how can we take into account who I am, but also the unique characteristics of the cancer that we're trying to treat. So, you know, the goal of precision medicine is instead of kind of a one size fits all, can we really dig in a little bit and understand not the disease itself, but also the person, so that we can make more effective choices about how to treat. And I put this picture on here of a mechanic looking under the hood. You know, I think about this as a way of really getting into the under the hood of what makes a cancer wrong. I mean, what's wrong that led to that cancer? And so just like a mechanic digs in to understand what's wrong with a car engine so they can fix it specifically, the idea is doing the same thing with respect to cancer. So, you know, we'll come back to this idea. Precision medicine is not all about the cancer. It's also understanding us. And we know that we're very, very different. And from a doctor point of view, and I think all of you can probably identify with the fact that we can take one medicine, pick any medicine, a cholesterol medicine, for example, and you can give it to 10 people and get 10 different responses. And so the more we understand about the people that we're treating also helps us make more careful decisions about how we use the medicines. So just to talk about this idea of a biomarker. So, you know, again, when we think about something like lung cancer from way back when was defined as something that grew in the lungs. And we just knew one way to look at it when it was all first, you know, kind of sorted out many, many years ago. But then over time, you know, more and more people figured out, well, there's not just one kind of lung cancer. There might be a couple different kinds. And as the scientists got better and better at looking at smaller and smaller things, so looking at genes, looking at individual proteins, looking at all these very specific things, as I mentioned earlier, you can divide lung cancer up into all kinds of different diseases. And these differences here, we can use the term a biomarker. And so for most cancers, a biomarker will be a gene that's been changed, that's been damaged or somehow screwed up, let's put it that way. So this gene has been altered in a way that makes it perform incorrectly or not perform or overperform or something. And so if we can figure that out, this then becomes a biomarker that we can learn about and potentially use to treat. Now you'll notice at the bottom of the slide, they talk about biomarker testings there are lots of terms that are used, molecular testing and tumor profiling and somatic testing. And so all these different terms, we're gonna kind of lump together and call them all biomarkers. And I want to call out specifically this idea of genomic testing because there's a lot of confusion. Somebody can say, you know, we're going to do genetic testing or genomic testing on your cancer. And the immediate thought is we're figuring out whether I was born with something. And we're going to talk about that. But here, when we talk about a biomarker in a cancer, we're talking about something that occurred in the cancer, as opposed to something that people may be born with. So I think this biomarker, the term itself is an excellent term to use. So a biomarker that helps us understand what went wrong to cause the cancer. So the main purpose of biomarker testing is to help us understand the disease better. It may help us understand how bad it is. Is it going to be a little bad or a lot bad? And it may also help us understand that there are, wow, you know, here's a biomarker and there's a specific drug that's over there on the shelf that I can use that's going to turn that biomarker off and help. So it can provide a lot of different kinds of information and sometimes very practical information about how we can treat. So biomarkers can tell us, for example, how well a treatment may work. It can tell us how well somebody may themselves respond to the treatment. Is it going to make them sick or not? It may help us understand some of the drivers that tell the cancer how to behave, which is important in understanding, for example, prognosis. It may help us understand very basic things about how quickly the cancer will spread, or even the likelihood of it being cured. And there are some biomarkers that we are born with that are passed through our family, that themselves aren't cancer, but are a marker for the likelihood of us getting cancer. And so a lot of different examples like that. So we'll talk about all of these things. So here are some biomarkers that are specifically related to different cancers that can help us choose treatment options. And there's a lot of terms up here, and I'm not going to go over all these, but I just want to highlight a couple things. Actually, can you guys see my arrow? Okay, good. Okay. All right, so in breast cancer, a couple very important biomarkers are whether or not the breast cancer expresses an estrogen receptor. That's what ER means. And that's very important because if a cancer expresses an estrogen receptor, that usually tells us that the cancer takes signals from estrogen to tell it to grow. And so a long time ago, it was learned that, you know, if we can block that estrogen receptor, we can also block the growth of that breast cancer. And so that's a very important one. Another one that I'm going to point out is this PDGFRA. And the reason that's important is this is a gene that's mutated that tells this gastrointestinal stromal tumor to grow. And so there is a medicine that you can give somebody that's easy to take. It doesn't bother people very much. It's really not chemo. It's almost like in some ways, it's almost like a blood pressure medicine. And if people take this medicine every day, then it turns that signal off and these cancers won't grow. And the reason I pull this one out is because there's also a type of leukemia that expresses this BCR-ABL. And this biomarker are very similar. And in fact, we can use the same medicine to treat this gastrointestinal stromal tumor, which is a tumor that grows in the stomach, and also leukemia. One medicine will do the same thing for both of these diseases. And we only learned that when people figured out these biomarkers and somebody said, wow, these two biomarkers look exactly the same. And I bet this medicine will work for both. And so there are a lot of other very interesting examples about that. Whereas if we just relied on the old way of saying, well, here's a cancer that grows in the stomach, so let's use, you know, stomach cancer type chemo. And no one would have ever thought about using a leukemia medicine. Only when we learned about the biomarkers did these other opportunities arise. So I'm not going to go through all of these, but I, again, want to point out one other one, this IDH1 and 2. Here's another example where the biomarkers are similar, in this case, between a type of brain cancer and a different kind of leukemia. So a lot of very interesting things come about when we learn about the genes that get changed that make the cancer do its ugliness. So when you're seeing your doctor, you know, a very good question to ask is, does my cancer have a biomarker? You know, is there a particular test that can be sent to tell us more about the cancer, how it's going to work, and what treatments might be available? And then if there are biomarkers, it's very important to ask, well, you know, how does that help us? How does that help us choose treatments for the cancer? So I'm going to pause here, and in this talk, there are going to be a couple times where we'll pause, and I'm going to let there be a little bit of silence here to let people collect some thoughts. And if you have any questions, please ask them. We'll talk for a little bit and then move on. Or obviously save it and we'll talk about it later on. Okay, so now here's another term that you hear a lot, targeted therapy. This is an important term, and it does have specific meaning here, because what this is talking about is there a treatment that is specifically working to address a biomarker? And so I'm going to use an analogy that I hope is helpful. A lot of people have high blood pressure. And when you are given a blood pressure medicine, most of these medicines have very specific targets. And so if somebody's treated with, for example, amlodipine, and I just picked that as one example, that's a common blood pressure medicine. Amlodipine you take, and it has a very specific effect to treat a biomarker that we all have that relaxes our blood vessels. And so this is a similar situation, and the reason I'm making this distinction is people sometimes think that anything that a cancer doctor gives you is chemotherapy, and therefore it is a poison that kills things and makes your hair fall out and makes you sick. And while there's lots of medicines that do have those kinds of side effects, a lot of targeted therapy, I think, are much more like the example that I just gave with the blood pressure medicine. These are medicines that have very specific effects and have very specific targets. And because of that, sometimes, not all the time, but sometimes the side effects are much, much less. And these then become treatments that people can take, like a blood pressure medicine, where you just get up and take the medicine every day. It doesn't have a huge impact on quality of life. It could work out that way. And they can be very effective in keeping cancers away or treating cancers that have come back or whatever the case may be. So targeted therapies block specific biomarkers that often can keep cancers from growing or otherwise doing things that we don't want them to do. So these targeted therapies, it would only make sense that you would only use a targeted therapy if the cancer actually had the biomarker for which it was intended to be used. And in the case of some of the leukemias, for example, that I take care of, I know that these treatments are super effective when the biomarker is present. But if the biomarker is not there, it's a total waste of time. It will not do anything. And so it only makes sense to use the treatments when we know that the biomarker is present. So these targeted therapies can work lots of different ways. One example of how these work is there's some medicines that can be given that actually, what the word they're using here is tagging. So it can actually attach to the cancer cell in a way that the cancer cell now is suddenly visible to the immune system, and your own immune system can attack it. There are other targets that if you inhibit the biomarker, the cancer cell just dies. It needs the biomarker to survive. Some of the biomarkers are present to help make the blood vessels grow, because to have a tumor, you have to have blood vessels. We talked about the estrogen receptors. Some cancers need hormones to grow. And then there's also some very specific treatments that actually unhinge the immune system, so that the immune system all of a sudden is hypervigilant and can just see everything. And in that setting, will have a tendency to attack certain cancers that carry biomarkers. So a lot of different effects. So the tagging cancer cells, I think the way I think about it, it's almost as if these targets, it's like spraying the cancer in fluorescent orange. Your immune system couldn't see it. All of a sudden, there it is. Now the immune system can see it and can attack it. Some of these biomarkers actually make the cancer grow, and so you turn those off, the cancer will die. We talked about the blood vessels, and so there are certain molecules that are needed for the blood vessels to grow into a tumor. Well, you can turn those off, and then those blood vessels die off. And then the hormones, the estrogen receptor is the best example of that. You can block that estrogen receptor, and that cancer will die off. And then the one that you see actually, there are a ton of advertisements about these because these are these immune checkpoint inhibitors, or the names can work in lots of different kinds of cancers. And what these treatments do, as I mentioned, it kind of takes the brakes off the immune system and makes the immune system sort of hyper so that it can kind of see all kinds of things, including the cancer. So, you know, when you're hearing about targeted therapy, it's of course important to understand how that targeted therapy might affect you, and also how it might affect the treatment. And then they're talking about some very practical things. A lot of these treatments we feel carry little risk, but some of them carry a lot of risk to family members. And so want to be very careful. If you come to the treatment room to get chemotherapy, there are the nurses who have special training are handling all those medicines that can be dangerous. But sometimes we're actually giving people a bottle and sending them home, and what's in the bottle is dangerous as well. And so for people that have children or might have grandkids or other people at home, it's important to understand really what is the danger. You know, if I don't like these, can I just throw them in the garbage? And, you know, how am I going to handle these? And I think those are very important questions to ask. Probably the pharmacist is going to have the best information, and the nurses as well. Okay, so let me stop here and pause for a minute and just see if people have questions about receiving treatment or what targeted therapy means, side effects and other issues. Okay, again, I'll move on, and I want you to feel free to, if something catches you up, feel free to bring that question up as we continue to talk. So there's, again, a long list here of targeted therapies, and I'm just going to pull out a couple common examples to point out. So the one on this list that is the oldest, that's been around the longest, is something called tamoxifen. And this has been around a long time. It is a targeted therapy against the estrogen receptor. And so there are many medicines like it, but it's been something that maybe people are most familiar with. And then there are many, many other kinds of treatments, and each one of these
Mark, are you still there?
specifically affect a target that tells the cancer to grow. And so any of these, when you see NIB, these tends to be medicines that inhibit how the cancer grows. These MABs tend to be medicines that target tag the cancer cell so that the immune system can see it. And so there are lots of different examples, but these are all targeted agents. And then earlier, I gave an example of a targeted therapy that was actually approved for a type of stomach cancer and a type of leukemia. And here are some other examples. This MSI high, what this relates to is a certain way the cancers process their DNA. And so there are multiple types of cancers that process their DNA very poorly. And what that means is that there's lots of mutations. You can see all these mutations going on. And so cancers that have that, whether it's a lung cancer or a breast cancer or other kinds of GI cancers, all of these have a tendency then to respond to medicine that unhinges the immune system. And so this pembrolizumab is a treatment that can be given and can be very effective for multiple different kinds of cancer, all for the same reason. And so this highlights the importance of understanding these biomarkers, because one treatment all of a sudden can be effective for many different kinds of cancer types. And then there's also something called NTRK gene. And this is a very rare type of mutation, but it's something that's seen also very rarely in multiple different tumor types.
Hmm.
And so if somebody were to have to happen, if it were to happen that somebody had that mutation in their cancer, then one medicine could be used for these different types. So lots of examples like this. Now, these targeted therapies all have different functions. They all do different things. So it is difficult to say, to give kind of a across the board side effect profile. And I'll again highlight some differences between these medicines and what I'll call chemotherapy. So most of the chemotherapy medicines we give all work generally the same way. They're poisons that cause damage to cancer's DNA. And because of that, they all have relatively similar side effects of nausea and low blood counts. But these targeted therapies all have very specific effects. In general, they do have a tendency to cause rashes. They have a tendency to make the skin dry out. And there's some itching and fatigue and flu-like reactions. And again, this is somewhat across the board. And of course, not just targeted therapy for cancer. These are problems with many different kinds of medicines, including antibiotics. So what's important is to ask your physician, what are the specific side effects that could be serious or dangerous? And so, for example, some of the medicines that inhibit blood vessels can cause very bad high blood pressure. And so if somebody's on one of those, we need a plan to really watch blood pressure very carefully. And that's a side effect that's very unique to those medicines. So while there may be common side effects, this is a time that you want to ask, what are the serious side effects and what do I need to do to monitor my own health to make sure that I'm looking for any of these more serious side effects? And so here's a general statement. These targeted therapies are not necessarily used alone. Sometimes they can be extremely valuable when used with some of our more traditional type of therapies like chemotherapy, radiation therapy, immunotherapy, or hormone therapy. So they're giving an example here of something called HER2-neu breast cancer. And so just to explain this, HER2 is a specific marker that lives on the surface of these cancer cells. And in addition to living on the surface of the cancer cell, this marker will tell the cancer cell to grow through a signaling that occurs inside the cell. And so, as is indicated here, there are 5 different ways that drugs can target the effect of HER2-neu. There's an antibody that can tag the cells by binding the HER2-neu on the surface of the cells and lighting the cell up so that the immune system can see it. There are also drugs that can block how this HER2-neu signals inside the cells. And so this HER2-neu is very important in what I'll call the pathology. It's very important to how these cancer cells do their damage. And so if HER2 can be targeted any of these different ways, then that typically can have a real favorable effect for the patient that may have a HER2 positive cancer. All right, so what are the limits? Well, the limit is that not everyone has a biomarker that we can target. And so it's amazing how quickly this area has exploded, and more people do have biomarkers, but definitely not everybody. And so these treatments can benefit some, but not all. And then also, sometimes people may have the biomarker, but the treatment doesn't work. And so not all these biomarkers work the same way. And you can have mutations that cause the biomarker in different ways, and some work better than others and some don't work. And then also, for the most part, these targeted therapies don't cure the disease. And so what they can do is put the diseases in remission, sometimes make them dormant. And in the case of one of the leukemias that I treat, the disease can become so dormant that it just stays there for years, years and years, almost so that people have a life and a quality of life that looks almost normal. But it's still not a cure, because if we stop the treatment, the disease will start to grow again. So in that way, it's a little bit almost like diabetes. For most people, we can put them on medicine to treat their diabetes, and the diabetes seems like it goes away, but it really doesn't, because if you then stop the treatment, the diabetes comes back. So in many people, that is how these targeted therapies are. Okay, let me stop there again and see if people have any specific questions. And so I'll go ahead and move on. So let's talk about cost. There are really two costs to consider. One is the cost of getting the biomarkers tested, and the other one's the cost of the medicines. And I'm just going to make a global statement that the biomarker testing is expensive. It's nothing even close to the testing, excuse me, the cost of the medicines. And so one of the issues that sometimes we get into is getting approval to get the actual testing done. And the argument that we make to insurance companies is the testing of the biomarker is nothing compared to the cost of the medicines. And so if you're a company that has to pay, you really, I think they have a vested interest in knowing what the biomarkers are so that we can choose the best treatments, which are super expensive. And so if I'm paying the bills, if I can put myself in that role, I want to make sure that we're choosing the treatments that have the greatest value. And those are the treatments that I can make safe predictions are going to work. And so I think the biomarker testing comparatively is huge, is hugely small. I'm not saying that right. The biomarker testing is very small compared to the huge cost of the treatment. But we all live in the real world, and some of this testing can be expensive, particularly if there's a type of testing where you're testing for like all kinds of different genes at one time, and that testing is even more expensive. So this is where this idea of a clinical trial can be really helpful. So clinical trials is the term that's used when we're doing research to figure out the best way to treat somebody. And this, of course, is hugely important. And the best clinical trials that are going on right now are trials that are largely funded by your tax dollar through the National Cancer Institute. And when the National Cancer Institute sponsors a trial, they build in testing for these biomarkers in a way that's usually it's free. It's just part of making these research studies work. And if you ever have an opportunity to be a part of a clinical trial sponsored by the National Cancer Institute, I would strongly encourage you to look at participating, because they tend to be extremely well done. They're well funded, and they're really oriented to making the best of the opportunity. Now, companies that make these medications are also have a very vested interest in making these things work, and often will also cover the cost of these biomarkers. So these are the type of things that are worth good questions to your medical team to make sure about, cover the cost. Are the costs going to be covered? And how do the clinical trials work in that regard? The other thing is that, Gilda's Club is an advocacy group, and there are all kinds of advocacy groups that are very well organized to lobby on patients' behalf to get these things covered. And even if they can't get them covered by the insurance company, often there will be benefits that help reduce the cost. So maybe the cost won't be zero, but it might be reduced to at least make it affordable. And the companies that actually do the testing, for example, Foundation Medicine is one, Caris is another. These are all companies that do the testing. If the testing is going to be valuable but too expensive, often they have also programs to help at least partially cover the costs. Now, the therapies, as I mentioned, these are incredibly expensive. These are some of the most expensive medicines on earth right now. And when they're FDA approved, usually there's some pretty good coverage. But I'm going to be quick to point out that even an insurance company that's covering 90% of a medicine, that might seem like a great deal. Well, if the medicine is $100,000 a year, 90%, well, that leaves a lot of medicine left to be covered. And right now, $100,000 a year is not unusual for a cost. So if you're choosing pharmacy benefits and you are having to make decisions about your health in the setting of having a cancer, the cost of premiums obviously is important to consider, but the cost of the medicines that you might need is really important to consider. And I would always encourage people to, do what they can to have really, really good insurance. I'll mention that most of the companies that make these medicines have programs to make it easier for people to get assistance for co-payments and other things like that, because of course they have a very strong incentive to help you get the medicines as best you can. We have here at UW, I think, a pretty good medication assistance program. And so it's important to take advantage of all these benefits and to really tap into all the coverage that's out there, not just from insurance companies, but from the pharmaceutical companies and advocacies and all these different areas. And the medication assistance program here does have pretty good information on how to do that. And I'll put a plug in for the cancer support community that also obviously has a website here that they are mentioning. Okay, now I'm going to transition to a different kind of biomarker testing. Before we are talking about biomarkers that exist in the cancer that are not something that people were born with. And now we're going to talk about a biomarker, which really is a marker in our bodies that might tell us more about our risk of getting cancer. And so one of the things that we're learning is that, we're all born with different tendencies to get diseases. And so in my family, we have some tendency towards breast cancer. We also have some tendency towards heart disease. And I know that there's some genes that run in my family, not the genes that you might be familiar with, but there's some genes that run in my family that don't give me cancer, but raise the chance that I might get cancer. And so how does that help me? Well, it helps me because I know that most people that have some of these genes don't get cancer. It just happens to be my risk is higher than other people without the changes. So that's what we're talking about here, the kind of genes that we were born with that may influence our risk for any disease, but here we're going to focus on cancer. So here we're talking about genes that run in families that can be passed through families that may increase the risk of getting a cancer. And I want to, again, make this very important point. These genes are not cancer, but these are genes that may increase the risk of getting cancer. And so it's not the same thing. So an inherited cancer there is such a thing as an inherited cancer, but it's extremely rare. Here we're just simply talking about how we're built, how we're made up. That's going to increase our chance of getting a cancer. Now there are biomarkers, again, that talk about tumors, but here we're talking about biomarkers or genetic things, genes that we are born with that may increase our odds. So when we use the term genetic testing, here we are specifically testing basically the genes that you were born with to see whether you may carry something that may increase the chance of getting a cancer. And not only does it increase the chance of getting a cancer, but some people who carry these biomarkers may benefit from a treatment. And this is the one that's most obvious. So you may or may not be familiar with something called BRCA, BRCA. And so there are people that are born with a certain type of BRCA gene that works and does what it's supposed to do, but it also increases the chance that people may get breast or ovarian cancer. Well, if people do get breast or ovarian cancer and they were born with one of these BRCA genes, these people do better if they're treated with something called a PARP inhibitor. And so it's important to know whether they were born with this BRCA gene. And here, this is genetic testing to see whether somebody may have been born with BRCA. And this is the same testing that women have, that you've heard about, who have had, for example, to figure out whether they may be at higher risk to get breast cancer, and they may then undergo some sort of treatment to reduce that risk. Here they're making the point that there's BRCA testing of the cancer, but there's also BRCA testing of you. And we'll make a distinction between the cancer and you. What they're talking about here that we just alluded to, BRCA testing can determine whether a woman has increased risk for ovarian cancer and breast cancer. But people may also develop a tumor that's BRCA positive, which may or may not be related to having the BRCA mutation, being born with it. All right. So there's some resources that are listed here that talk about this and go through that. I feel like what I just talked about, it might have been a little bit confusing, so I'm happy to talk more about that and maybe come up with some other examples. And I'll stop here and see whether people have more questions. And I think that's our last slide. So, okay. Okay, here we are. Okay, so here I've got to rearrange something here real quick on my screen. Okay, so there is a cancer experience registry that is available, and I'm here. I'm having a little bit difficulty here. Okay, here we are. So for those of you that are interested, there is a registry that you can join, and this is something that's sponsored, of course, by the cancer support community, and this helps collect information. So let me give you a larger context of what I think this is. And again, I'm presenting information from the cancer support community. So back when the Affordable Care Act began, there were a lot of patient groups that got together and said, you know, if you're going to reform insurance, you need to do a better job in gathering the experience of patients and sorting out what patients are actually going through. And so part of that law created something called PCORI, which is Patient-Centered Outcome Research Institute. And they have sponsored lots and lots of different projects and organizations, and kind of helped create a whole culture of collecting information from patients. And so the jargon that we use is a PRO, so a patient-reported outcome. And so many advocacy groups and lots of research and lots of health systems, everybody is trying to get involved with this ability to collect patient-reported outcomes. So how can we collect the experience from patients' point of view, not just, for example, ask the doctor, how did your patients do? you know, I think they did okay. Well, let's get it directly from patients. And it turns out, not surprisingly, that this is hugely valuable. And patients come up with ideas all the time that doctors and nurses and health systems don't think about. Not because they're bad people. You think about things differently if you're experiencing it than you do if you're watching it. And so I think this is really an example of that, where they are asking people to contribute to a registry about what it's like to be in your shoes. And this gives them information that they then can bring back to people like me who are trying to figure out, you know, how do we design the system better? What do we need to do to meet people's needs head on? And so this is a place where you can contribute. Kirsten, anything you want to add to that?
So I can say, as a participant in the registry, this has been a real game changer. And as somebody who's benefited from looking at the registry in terms of getting patients' perspectives on their lived experience, their emotional experience, you know, what happened, what worked well, what didn't work well. If you know, I highly encourage people to participate in this. There are, I think, 7 specialty areas. They look at cancer in general, but they also are looking at women with breast cancer, men with prostate cancer, and caregivers, and stomach cancer is one of the sub-registries. So it's a really great opportunity to participate in patient-informed research. So I think it's just, I think it's been really great, and it has helped a lot of folks, and we use it in our research stuff, and a lot of other folks. I've referenced it with some of the meetings that I'm in with other cancer organizations.
I think the other way to look at it too, this is one way to have your voice heard.
Yeah, absolutely.
So be heard. All right. And then this is something I think is very interesting. I have to be honest, I don't know very much about it. So, Chris,
Mark, if you want, I can talk about this if you'd like it a little bit. So mylifeline.org it's sort of like CarePages, but in addition to your interactive blogs and updates and things like that, you can tap your network for helping calendar. If you are in treatment and you need rides to treatment, or people to take your dog for a walk while you're at chemo all day, and there's discussion boards, and there's care coordinators who can sort of like drive the bus so you don't have to deal with it. You set up your own page. It's really wonderful, and a lot of different layers to it. Has been really helpful for a lot of people. And the thing I love about it is that you've got your outpouring, your own processing and writing that you can do with your blogging and your updates, but also tapping into your folks to get help. Because as supporters, people want to help, but they don't know how to. As somebody who needs the help, sometimes we're asking for people for help that might be at the wrong time or the wrong activity. And if there is something specific that you're asking somebody to do, and they say no, it's really hard to screw up the courage to ask somebody again to do something. So it's a great way to be able to tap your team. And it's all privacy protected. Thank you.
Okay. All right. So let's see. Yeah. So that's the last slide. Any final questions that people have?
I have a question about